about spasmodic dysphonia, and we're really just giving an overview. This is really meant to be patient-oriented, just giving some information about the different types of spasmodic dysphonia, the history of spasmodic dysphonia, some different treatment options available. Spasmodic dysphonia, of course, is a very devastating voice disorder that many patients have to live with for a lifetime, and many patients go undiagnosed for years. And so it can be very stressful, very, very challenging for the patient and their families. So we just wanted to share some information with them today. So if you look at a history of spasmodic dysphonia, it's very interesting. It wasn't until Traub described this in 1871 as spastic dysphonia that people started really recognizing it as a disorder. And they really didn't know what caused it. And so to understand what's causing spasmodic dysphonia, it's important to understand the anatomy. And if you look at the anatomy, we actually have three separate muscles that close the vocal cords. So we have the lateral cricoarytenoid muscle right here. We have this interarytenoid muscle, and then the thyroarytenoid muscle. And all three of those adduct the vocal cords. Adduct, adduct, means close. So in patients that we say have adductor spasmodic dysphonia, we're saying that these muscles are not behaving appropriately. These muscles are having spasms, and those spasms cause the vocal cords to close inappropriately. So in the middle of a word, someone's saying rainbow, and it comes out rainbow because these closing muscles suddenly spasm. And it can be different muscles, which is also a challenge with adductor spasmodic dysphonia, that some of these muscles can be more active than others. Now there's another spasmodic dysphonia subtype called abductor spasmodic dysphonia. So this is controlled by typically just one muscle. The abductor breaks are caused by just one muscle that's called the posterior cricoarytenoid muscle. Here you can see that posterior cricoarytenoid muscle, when it fires, it actually causes these vocal cords to fly open. So in this case, patients are talking and they might say Patty, and it comes up Patty because those vocal cords fly open in the middle of their speech, and that leaves them with very breathy breaks. And of course, if you look at what this muscle is doing, this muscle is actually opening the airway. So that makes it a real challenge to treat, because if we were to do either a denervation procedure or inject Botox, which is a chemical form of denervation, we're technically weakening this muscle that opens the airway. And in fact, what we'll see when we treat patients with abductor spasmodic dysphonia with Botox, we'll see that these vocal cords won't be able to open as much after the Botox. And we can get to a point that they really can't breathe well at all because we put so much Botox in that their vocal cords really can't open well, and they really struggle with their breathing. And so this tends to be our most difficult form of spasmodic dysphonia to treat, simply because it is the only muscle that opens up our laryngeal airway, and so it really restricts how much Botox we can put in safely, and what kind of result they're going to get from a voice standpoint. But we'll have more information on that upcoming. But that's a little bit of the underlying anatomy. So when this all works well, this is what it looks like. This is a normal patient, and you can see when they bring their vocal cords together, what we're seeing here are these adductor muscles, these muscles that close the vocal cords. Those are all working in harmony. So we have the interarytenoid muscle back here, our underlying thyroarytenoid muscle, lateral cricoarytenoid muscle. These muscles are all working in harmony to hold the vocal cords together. And then the patient is just allowing air to flow through this vibratory portion of the cord. So there's no muscles actually right in this vibratory surface. And by holding these muscles still, that's what allows us to get that nice, smooth, steady voice. So you'll see as he's holding his voice, holding this E, we get that nice, smooth, clear, steady voice. And this is strobe, which allows us to see that vibration of the vocal cords. But it's his ability to hold those muscles steady that allows him to get that nice, steady, smooth sound. And then here you can see as he takes a breath in, that's where that posterior cricoarytenoid muscle is activated, and he's able to open up the vocal cords and open up a nice normal airway so he can take a big breath. Now, what happens in adductor spasmodic dysphonia is quite different. So this is a patient who has adductor form of spasmodic dysphonia, and we are looking a little more from a distance, so we're not seeing that super close-up view. But what you'll hear...
3, 4, 6, 7, 8, 9, 10.
So you can hear as she tries to hold her vocal cords close together, these muscles are spasming. And it's that spasm that of those adductor muscles that's interrupting her continuous voicing. And you can hear it also with her continuous speaking, that especially during vowels, she's having these adductor or these closing muscle breaks that are making her voice sound very, very tight, very strained. And you almost lose visualization of the actual vibratory vocal folds as she's speaking because of all these adductors being so overactive. So the other interesting thing with spasmodic dysphonia is that, you know, for over 100 years, it was thought that this was something functional or psychoneurotic. They thought that this was somehow stress-related. It was related to something other than, you know, being an organic cause. So it really wasn't until 1960s, 1970s that this became recognized as having an organic cause and being recognized as the neurologic disease that it is. And so Dr. Dito described this in 78. Actually, Dr. Aronson described in 68 the muscles involved. So he was starting to recognize it as a neurologic disease, you know, back in the 1960s. And he described these two subtypes, the adductor spasmodic dysphonia being the type where the vocal cords are closing too much, essentially, and then the abductor spasmodic dysphonia being the subtype where the vocal cords are flying open in the middle of speech, and that's causing breathy break. And then Dito described back in the 1980s something to treat this. And the thought was that if we're dealing with a situation where the spasms are causing too much closure of the vocal cords, well, maybe we can just cut the nerve. And maybe cutting the nerve would allow these patients to have more of a breathy sound, and they would eradicate the spasms. And in fact, you know, in that way, it did work. About half the patients had eradication of their spasms. However, you know, some of them did re-innervate. So sometimes the nerve regrows, basically. And in those cases, they did begin to have spasms again. And in the patients who didn't have spasms, you know, it was somewhat of a trade-off. So they're cutting the recurrent laryngeal nerve. And in doing so, you're actually inducing a vocal cord paralysis. So remember in the original videos we showed, or the original video I showed today, we could see that those vocal cords were opening and closing appropriately. After we cut the nerve, this is what happens. So this is a case of a patient where this side is not moving. You can see the right side moving open here and then closing here the way it should, and this left side has had a nerve injury. So the nerve has been cut on this left side. And you can hear, so you can hear and you can see that this patient essentially now is left to work with a leaky valve. The voice is almost a whisper, and so the patient doesn't have spasms anymore, but the patient doesn't have a good voice either. So it's not a great trade-off. And in some of these cases, we can go back in, we can actually inject filler substance, or we can put medialization implant into the paralyzed side, which does close the gap and makes the voice stronger. But what we found over time is as the nerve reinnervates, a lot of times the spasms come back again. And as we close the gap, a lot of times we hear the spasms coming back. So this has become less than an ideal treatment over time. One of the probably breakthroughs in the history of spasmodic dysphonia is the botulinum toxin being discovered as a therapeutic agent. So this was originally described by Dr. Blitzer and Brin, and they were using it for other forms of dystonia and began trying it for the larynx. And of course, you can imagine at the time that this was quite a stressful event, because here they're putting, you know, what was thought to be a poison for many years, and really just recently in the 1980s here was being used therapeutically. And now they're putting it into these muscles of the voice box, you know, very close to the airway, and actually the muscles that are the gateway to the airway. So of course they were quite concerned about what would happen, and they were both involved in speaking at our neurolaryngology national study section a couple years ago, and described this whole scene, and it was very interesting. They talked about the patient coming in, and they did the injections into the vocal cords, and then they actually kept the patient in the ICU for monitoring, being very concerned that, you know, something really bad could potentially happen. And of course, nothing happened, which was great. And a couple days later, the patient's voice got breathy, and the spasms resolved, and the patient's voice got much better for several months, and then it wore off, and they were onto something that was going to work very well for spasmodic dysphonia. And this is actually a slide from Dr. Bren from that talk. And he was describing some of the mechanisms of action of Botox. So one of the main mechanisms that we all know about is that the Botox prevents release of acetylcholine. So in that way, it actually is creating a temporary chemical partial paralysis of the muscles. So, you know, it basically blocks release of acetylcholine, which is how nerves tell muscles to fire. So by partially blocking some of that release of acetylcholine, we are chemically weakening the muscles. And it lasts for typically about, you know, anywhere from 3 to 6 months. Basically what happens is the patient's body starts making new acetylcholine vesicles, and the Botox is long gone, so now the nerve acts completely normally once their body has kind of overridden that initial Botox dose. And so when the Botox wears off, ultimately the patient goes right back to where they were before, and it doesn't change the overall course of the disease at all. There is also a newer concept, which is that Botox does have some pain relieving impact. We don't know at this point how much of an impact that has on our spasmodic dysphonia patients, but it is something that is also kind of an interesting aspect of Botox. So the other thing with Botox is that although at this point it really is the best thing we have, it really is the standard of care, there are some problems with it. It is not the ideal treatment as far as it's not that it is not, it's as good as we have, but there are side effects with it. There are problems with it. It doesn't work for everyone. One of the issues with Botox is that we often have patients who fall into this category of kind of a gray zone in diagnosis. So there are patients who have muscle tension dysphonia, and that can look very, very similar to spasmodic dysphonia. Muscle tension dysphonia is a situation where the muscles of the voice box are very tight, very similar to adductor spasmodic dysphonia. Although they tend to do very, very well with voice therapy, because theirs tends to be a situation where maybe the patient picked up some bad habits along the way, maybe some kind of real stressful event set something off, and those muscles went into spasm. But it's not a neurologic disease the way spasmodic dysphonia is. It's not the basal ganglia sending signals to the voice box. It is more of a muscular disease. And so muscle tension dysphonia does respond very, very well to voice therapy, whereas spasmodic dysphonia doesn't, because spasmodic dysphonia is a neurologic disease. So one of the problems with Botox is sometimes we're using it inappropriately if we are using it in patients who end up having muscle tension dysphonia. And of course, those patients won't get better. Although if they have pure adductor spasmodic dysphonia, then they tend to do extremely well. The other challenge, though, even with pure adductor spasmodic dysphonia, is you can have more than one muscle involved. And I think this, you know, in patients where they strictly have those thyroretinoid muscles that we were looking at, I mean, if those are the only muscles involved and they don't have much tremor, those patients tend to do beautifully with, you know, EMG-guided Botox injections. But some of our patients will have multiple laryngeal muscles involved. You know, Dr. Hillel has done some beautiful studies on this, looking at which muscles are involved with different types of spasmodic dysphonia. And he really demonstrated that many patients have mixed forms of spasmodic dysphonia where multiple muscles are involved. And you can have both the closing muscles and sometimes a little bit of the opening muscle being involved. So it can become extremely complicated. And so there are some limitations with Botox, and sometimes doing hooked wire EMG can actually be kind of helpful in figuring out which muscles are most active, and then we can really target those muscles a little better with our Botox. So this is a typical setup with EMG-guided Botox. You can see This is just beneath the laryngeal cartilage. So we saw that laryngeal cartilage that was housing the vocal cords. Just beneath this is a space called the cricothyroid membrane. And we're going to put our needle through this little cricothyroid membrane, and it goes right into those muscles of the vocal cords. So we can target the thyroarytenoid muscles, which are going to be more in the center, or those lateral cricoarytenoid muscles, which will be a little more over to the side, both within that thyroid or laryngeal cartilage. And what we're looking for when we do these injections, we're looking for the firing pattern. So we have the patient either say E, or sometimes when we get in there, we actually get this burst of insertional activity, so we know right away we're in the right spot. And then we just put our little bit of Botox in there, and typically they don't notice a real big difference right away, but several days later, anywhere from 2 to 5 days later, the Botox effects kick in, the voice becomes really soft, kind of like a whisper sometimes. And ideally, we want that period just to last a few days, sometimes up to a couple of weeks, but we want that breathy period not to be very long, and then to go several months, if possible, with more of a smooth, steady voice. And then it wears off, and then they come back and we do the whole procedure over again. So in the ideal world, that's what we shoot for with the Botox. This is just an example of the EMG that's handheld. So it just shows that there's some different options when it comes to EMGs, but it does the exact same thing that the larger unit that I just showed does. So as I said, adductor spasmodic dysphonia, there's 3 big adductor muscles, and when we do this EMG guided Botox, where we're going through the front of the neck there, you can see where our needle is actually coming. It runs right underneath this cartilage. This cartilage is called either thyroid cartilage or laryngeal cartilage. It's the same thing, just 2 different names for the exact same thing. So we're running between the cricoid cartilage, which is down below, and the laryngeal cartilage or thyroid cartilage, which is up above, and we're inserting our needle through there. And then you can see that typically our needle is going to end up right about in this area where we can be in the thyroarytenoid muscle. This isn't the best representation of the lateral cricoarytenoid. It's actually a little broader than this. So we can angle our needle and get over to the lateral cricoarytenoid, but it is more challenging. So if someone has a lot of lateral cricoarytenoid muscle involvement, or if they have a lot of interarytenoid muscle involvement, sometimes we can be fairly limited with our EMG guided Botox. One of the alternatives we have for those patients who go through that real breathy period and then the effects of the Botox wear off and they don't get a real good stretch of clear voicing, there was a procedure that Dr. Blake Simpson described where basically he injects a wheel of Botox into this complex or into this area superficially above that lateral cricoarytenoid muscle and above the thyroarytenoid muscle. And that seems to have been really helpful. I use this for a lot of my patients who are not getting ideal effects with the EMG guided Botox. We'll use this approach, especially for those with tremor. I think this can be really helpful because one of the challenges with tremor is it often involves multiple muscles, and so the more muscles we can reach in the larynx, sometimes that can be much more helpful for these patients. So this is an example of our setup. We have topical lidocaine, so we apply this topically to the larynx. We have a scope that has a little channel on it, a flexible scope for the nose, and then this little working channel we can administer lidocaine through it, and we can also put our injector needle through it. So everything goes through the nose, so the patient doesn't have to have anything going through their mouth. And this is just an example of the needles that we use for that scope. And this is an example of the actual procedure. This is the scope that's already through the patient's nose. So here we're already through the nose, and here's our little needle coming through that working channel of the scope. And here you see, as this goes down to the larynx, here's the patient's larynx. This is the patient actually had a nerve avulsion procedure. You can see his left vocal cord is paralyzed because of having that procedure years ago. But he already is having spasms again. So we are injecting a little bit of Botox into both sides. And we're trying to keep it very superficial there. We go back into the right side here. This is, of course, the moving side. So we usually inject a little bit more into the side that's moving. And then we're done. You can see that we've gotten these superficial injections on both sides. And that patient has done really, really well with this. He was having more ups and downs with the EMG guided Botox, so doing it this way has been very, very beneficial. One of the other things we have as a challenge is treating our patients with abductor spasmodic dysphonia, and I alluded to this before. But one of the problems with abductor spasmodic dysphonia is the fact that this is also the muscle that opens our laryngeal airway. So if we inject too much, patients do have difficulty breathing. They'll actually, have noisy breathing. They'll have stridor. They might sit on the couch for a week and not be able to get up and do anything because they're struggling to breathe. And so sometimes we have to go to that extreme to get them to the point that so it's not a great trade-off sometimes. The other challenge with it is where it's located. If you look, if this is the front of the patient's head, and this is the back of the patient's head, this is where that posterior cricoarytenoid muscle is located. So when we go through the cricothyroid membrane here, so when our needle goes through, we have to bore a hole in the cartilage to get to this posterior cricoarytenoid muscle. So if we're doing it from this view, we would be going through this little cricothyroid membrane here, going all the way through the airway, actually boring a hole with our needle into this cartilage to get back to that muscle. So it's a very challenging muscle to treat. The alternative is coming in from the side. So sometimes we'll turn the patient's head really far so we can come in from the side to try to reach that muscle. But the challenge with that is there's a lot of swallowing muscles around here. So when we come in from the side, sometimes we'll have some difficulty swallowing because the swallowing muscles overlap those posterior cricoarytenoid fibers. And so a very challenging type of spasmodic dysphonia to treat. So there are some surgical options. I don't think surgery is really the ideal option, at least not surgery at the end point, because we're talking about neurologic here where, basically we have neurologic input from the basal ganglia going down to these muscles of the voice box. And so just treating the voice box, I don't know if that's the right approach. And what tends to happen is people do well for a while. Sometimes they do well for a year or two. But in my experience, when we've done these different surgeries, I find that after a couple of years, a lot of these adjuncts and patients start to have the same problems again. A lot of times we're back to considering but there are some options out there that we should at least discuss. The framework surgery is one option that has had interest both with physicians and patients. This is a procedure that's been described for a very long time, but just really over the last 10 years, there's been more interest for it for adductor spasmodic dysphonia. But you'll see this lateralization thyroplasty. What we're doing here is we're actually creating a cut right down the middle of the laryngeal cartilage, and then we're going to pull these two sides apart and use titanium to plate the laryngeal cartilage so that on the inside, creating more space between those vocal cords. And so we're literally pulling those vocal cords apart so we end up with some breathy hoarseness and we can't hear the spasms, and the spasms aren't nearly as tight. And I'll run through that in a little bit just to give you the long-term results with that. The other thing that can be considered is utilization theraplasty, and this is something I have done a little more of simply because we use it for abductor spasmodic dysphonia, and I feel like an abductor spasmodic dysphonia treatment options that help. And so by putting in implants into these patients, it really makes the voice quite a bit stronger. And it may not stop the breathy breaks, but if we use this first, if we put implants in, we bring those vocal cords close together, and then maybe in a year or two, they start to have breathy breaks again, and we still have Botox as an option. So I use it more in conjunction, with, or at least with the plan that ultimately we need some Botox down the road, but it should make the overall stronger, and it seems to work pretty well in that regard. The lateralization thyroplasty has been described by different authors, and I will say different authors have had very different results with long-term results are by far the best out there. And they've seen, they reported 15 patients for at least 2 years follow-up and found patients were all very satisfied with their voice, and there was significant improvement in the different groups. Unfortunately, it's not been something that others have been able to reproduce real consistently. recently, but I do think it certainly warrants continued investigation because their results have been quite good. As I mentioned, medialization thyroplasty is something to consider for adductor spasmodic dysphonia. And again, this isn't really treating the cause of the disease, it's really treating the end organ. But it does push these vocal cords closer together. So in the case of adductor, it helps prevent them from, from flying apart quite as much. And it just helps bring the cords together so their voice is a little stronger. This is an example of a patient with abductor spasmodic dysphonia. And you can hear those breathy breaks.
One, two, three, four, five, six.
And you can appreciate it has a very different sound than the adductor type, which sounds so tight. This tends to sound breathy. And even with sustained E, often these patients will have some difficulty keeping their vocal cords together, which was one of her points of frustration. She just could not get loud, couldn't project her voice, had the breathy breaks, and worked on the phone. And so the combination was very challenging, and she really did not want to have Botox treatment. So in her case, we did do implants, bilateral medialization laryngoplasty. This is her after the surgery.
4, 5, 6, 7, 8, 9, 10. Peter paid Paul. Peter paid Paul. Good. And he hit Hal. He hit Hal. Good. Big breath in, and I saw E. Good. E.
So she was very pleased with the improvement, and the improvement lasted almost 2 years. But I will say she's already been back now a couple of years out and starting to have more of the breathy breaks. And I do think that's a problem when you're treating the end organ for what really is a central neurologic disease. The body tends to adjust and the disease tends to adjust, and then we start to have problems again. So there is one other procedure that I think is definitely worth mentioning. This is called the denervation reinnervation procedure that Dr. Jerry Burke out at UCLA described. And one of the problems with the nerve avulsion procedure is the reinnervation that occurs after that procedure, and the spasms, come back with that reinnervation. The other problem is that you're completely paralyzing the vocal cords. So he kind of went around both of these issues by cutting only the adductor nerve, so only the nerve that's going to those muscles that close the vocal cord, and then rewiring that with another branch of nerve, the ansa cervicalis. So by doing this, we avoid the complete paralysis situation, and it helps basically maintain some tone in that vocal cord, but we tend to have less of the recurring spasms. The challenge with this is it can be a very difficult procedure to do, and I think most physicians who have tried this procedure, we haven't gotten the same results that Dr. Burke has gotten. I think he's gotten very impressive results, and some fellows that have trained with him have gotten very impressive results. But most physicians don't get quite the success that he has had. And I know in my own hands, I've had patients who ultimately have come back and needed more Botox after this type of procedure. So it's, it's out there, but I think if one were to have a procedure like this, I would definitely go to a physician who does a lot of them. Ultimately, one of the things that I think the future of spasmodic dysphonia is going to hold is getting to the root cause of the problem. And there's certainly many studies now where they're looking at DBS, or deep brain stimulation, for various forms of dystonia. And Dr. Honey is a doctor who's investigating it for spasmodic dysphonia, and the NSDA is supporting that. So I'm looking forward to seeing what the future brings regarding that, because I think that's probably one of the procedures that is the most promising in the way of really getting down to the root cause of spasmodic dysphonia. So in conclusion, spasmodic dysphonia is a voice-specific laryngeal movement disorder. It's specific to the patient talking and voicing, which can make it very difficult to diagnose. It makes it difficult for people to understand sometimes. There can be variable presentations in the muscles involved, and in each individual is very, very different. So that makes it challenging as we're treating patients with Botox, because there just is not a single, one-fits-all kind of plan. Every plan has to be very individualized to the patient. And certainly some new treatment options for spasmodic dysphonia are warranted. So I look forward to the next 10, 20 years to see what new studies will bring, and do have high hopes for DBS and studies like that might be looking at the underlying cause of the disease, because I think in that way our future